Thank you, Dr. Ahmed, for this lovely introduction. It's an honor to be here today, everyone. I'm the only radiologist in this big room of surgeons with Dr. Ashraf طبعا, he's my professor. I'm a bit scared, بس يعني إن شاء الله تمشي كويس. Okay. So the role of preoperative imaging is defining axillary lymph node burden and selection of patients for sentinel lymph node biopsy. The presence of axillary lymph node mets and the number and location of the positive nodes determines the pathological stage of breast cancer. And so lymph node mets is the most important predictor for overall recurrence and survival, with the 5-year survival rate for patients with disease localized to the breast reaching 98.8%, and the figure drops to 85.8 for patients with regional mets. So our aim is to avoid overtreatment and understaging. And with this, I tell our dear radiologists, you may think that you are a kitten, but no, actually you are a lion, because depending on what you are going to say to the surgeon, the plan is done. And the overview of this lecture is, first of all, I'm going to go through the anatomy, some points on the TNM stage, what imaging modalities we use, a little bit about post-neoadjuvant chemo, and about breast intervention. So regarding anatomy, the previous lectures have discussed some of it, but we as radiologists, what are we supposed to do? We are supposed to look at level 1, level 2, and level 3 lymph nodes, and also scan the internal mammary region as well as the supraclavicular region. Now, the survival data say that when we have no lymph nodes with a smaller tumor size, the survival rate is much better. And if we look here, I think the mouse isn't working. Oh, quite, it's working. So here we have no nodal involvement with a tumor size of less than 2 centimeters. So the survival rate is very close to 100%. And if we compare in the same column here, the yellow one is with more than 4 positive nodes, and even if the tumor is less than 2 centimeters in size, the survival rate drops. Some points on the TNM that are important. N0 means no regional lymph node metastasis. Sorry. N1 is 1 to 3 lymph nodes and sometimes micromets to the internal mammary nodes, or a combination of both. N2A is 2 to 9 axillary nodes. N3A is more than 10 axillary nodes and may include infraclavicular, supraclavicular, or internal mammary. The types of surgery, I won't go through into detail, but I think we all know they're axillary lymph node dissection, sentinel lymph node, or targeted axillary dissection. And what imaging modalities can we use to evaluate the axilla? So this is a very nice table that was published in 2020 with a looking at all the published data, and we can see that ultrasound shows a very high specificity and sensitivity. Sensitivity about 87%, specificity goes up to 97%. And as Professor Rida Abdeltawab was mentioning about the PET MRI, and if we look here in this table, we'll see that the specificity in PET MRI goes up to 100%. In MRI, the specificity goes up to 90%, and the sensitivity is about 77%. However, due to wider availability, easier use, we mostly use ultrasound. How do lymph nodes look in mammography? Now, we can only see level 1 lymph nodes occasionally, okay? And how do they look? These are the normal lymph nodes. Normal lymph nodes would have a lucent center for the hilum. They would have a dense periphery for the cortex, and they would usually be oval in shape, okay? We can see any number. We can see 1 or 2, and we can see 10. And this is how the normal lymph nodes would look. Again, this is a normal axillary lymph node, lucent center, thin cortex. This is a pathological node showing all dense, okay? But mammography has a low specificity, so this could be a normal node as well. We have to look on ultrasound. It depends on which angle the node is compared to the view that it was imaged. Here we have some calcifications, and this is highly suspicious. And here we have multiple suspicious lymph nodes by mammography. An important note to say to the radiologists, if you see calcifications in the lymph nodes, it's not necessarily suspicious. Sometimes the patient can have a tattoo in her upper half of the body, and the tattoo will send calcifications to the lymph nodes. Okay, this is another case with a dense lymph node, single lymph node here, and this is how it looks on ultrasound with totally lost hilum. And again, this is another example showing thickened cortex here, and on the other side, these are normal lymph nodes. Again, another case with calcifications, and this is how it looks on ultrasound with all these hyperechoic shadows within the hyperechoic shadows within the hypoechoic lymph node. Okay, moving on to ultrasound, which is what most of us radiologists use. So it's the primary non-surgical method for evaluating the lymph nodes, and it is moderately sensitive, can be highly specific. And drainage usually, as we know, proceeds in a stepwise fashion from level 1 to 2 to 3 and finally into the thorax. Normal lymph nodes by ultrasound are very difficult to see. Okay, but why? Because they are mostly replaced by fat, by the fatty hilum. And the fatty hilum is very similar to the fat in the axilla. So it's sometimes difficult to see a normal lymph node. What is the pathway of lymphatic spread? Usually the lymphatic spread or the METs come into the afferent lymphatic. They can deposit like this in the center within, obliterating the center of the node. They can be just beneath the cortex. They can be extracapsular, or they can have a heterogeneous pattern of spread, which is why we're going to look at how it can affect the lymph node, how it looks. Now, regarding what are the morphological, pathological findings on ultrasound. Diffuse cortical thickness of more than 3 millimeters, as there was just a discussion with Professor Ahmed and Dr. Ashraf Salim, say that the cortical thickness is more than 3 millimeters is suspicious, yet it is relatively non-specific. So a lot of times we see a smooth cortical thickness and it's usually inflammatory. Okay, not all the time it's malignant. What is more specific is the morphology of the lymph nodes. The cortical bulge, the eccentric thickening, the extracapsular deposit, and I'm going to show you all of these examples. So here we have a normal lymph node, very thin cortex. Here we have focal cortical thickening. Now this is very suspicious. Here we have 3 lymph nodes that are almost matting together. Here we have, again, lobulations in the cortex. This is highly suspicious. And another example with just focal cortical thickening over here. And this example shows focal extracapsular deposits within the lymph nodes, and this is also highly suspicious. So if you measure the cortex here, it's going to be normal, but here, definitely much larger. So that's why we say morphology is also very important. Now, use of Doppler, okay, if we see Doppler at the hilum, that's fine, but something like this, of course, with an effaced hilum is suspicious as well when you find vascularity throughout the lymph node. And the anatomical location of the lymph nodes is very important for the radiologists to know. Here, the previous ones we were seeing were level 1 lymph nodes. Level 2 lymph node is beneath the muscle. We can see the muscle over here. And where should we scan? We should scan at the angle between the arm, okay, and the breast. This is where we look for level 2. And looking for level 3, we look beneath the clavicle, and these are some level 3 pathological lymph nodes. Okay, internal mammary chain. Radiologists should not forget the internal mammary chain, especially in medially located tumors. And these are all the intercostal muscles, okay, and the ribs. And an intermammary lymph node will be just over here. Okay, moving on to MRI. Now, the advantage of MRI over ultrasound is that it is better at evaluation of the internal mammary lymph node, and sometimes supraclavicular if you're going to view the neck as well. Yet it shows us a more global view of the axilla. It allows us to compare both sides together, and it is less operator dependent than ultrasound. However, the normal lymph node will uptake contrast and it will give a washout curve, okay? That's the normal lymph node. Not like the breast mass. The breast mass that is suspicious will give a washout curve. The normal lymph node will give a washout curve. But levels 2 and 3 may be obscured by artifacts, and sometimes we can't see them properly. Now, the characteristics of abnormal lymph nodes by MRI are very similar to mammography and ultrasound. But the most specific finding for pathological lymph nodes on MRI is perifocal edema around the lymph node. That has a positive predictive value of 100%. What does that look like? Here we have suspicious lymph nodes, okay? and this is the edema beside the lymph node. And this is another example in the coronal. This bright signal is all edema. This is perifocal edema around the lymph nodes, and this is highly suggestive of malignancy. Okay, again, level 1 and 2, we should be able to see them. Here we have a level 1 lymph node, and this is a level 2 lymph node, and here we can see that we are at a higher location above level 1. Oh, sorry. Okay, internal mammary lymph nodes here. Here they are on the axial view, and here on the sagittal view, right in the same location that we see them by ultrasound. Regarding chest CT and PET CT, chest CT is not routinely used to evaluate the lymph nodes. They can be commented on, of course, in a CT chest. However, they have the same morphological features. Here we can see some lymph nodes that are pathological within the CT chest. And internal mammary can sometimes be viewed as well. Here we have an internal mammary pathological lymph node, and here it is on ultrasound, the same lymph node. Okay, PET CT, also the high uptake by the SUV, and it's bright within the image. Here's the breast mass, here's the axillary mass, so these are also established methods of evaluating. However, PET CT is not usually done in stages 1 and 2. Now, in neoadjuvant chemotherapy, if we look here, these are all lymph nodes pre-chemo. Here we have a totally lost hilum, heterogeneous lymph node. Here we have cortical thickening and very thin hilum. And these, on follow-up after 3 months, we can see that this one has totally almost resolved, just a slight cortical thickening. And here on ultrasound, we can see that also the lymph node has remarkably improved in morphology and size. We don't use size to follow up chemotherapy or to assess the lymph node and say that, for example, it's 5 centimeters in size, so it's pathological. No, the size is not valuable for evaluation of malignancy yet. It's important for following up under neoadjuvant chemo. And on MRI, here is a case with diffuse non-mass uptake within the breast and pathological nodes. And here the uptake has decreased and decreased even more after 5 months, and the lymph nodes as well. So the axillary lymph nodes under neoadjuvant chemo, the greater the number of affected lymph nodes or the higher the affected level, usually we find slower response rate, and the HER2 positive and triple negative show a higher response rate. And usually we do marking for lymph nodes with 1 to 3 lymph nodes suspicious at level 1. Interventional procedures. So, regarding interventional procedures, biopsy, ultrasound-guided core biopsy is the method of choice. No MRI-guided or mammography-guided for lymph nodes. It varies in practice who does fine needle and who does core, but in our practice, we do core needle biopsy for lymph nodes. We find that it has better results. So we do core needle biopsy for all our lymph node cases. We should do color Doppler, definitely, to avoid large vessels during needle biopsy. This is a case that we had. This is the needle going into the pathological lymph node, and the lymph node here was quite small actually, but it turned out to be positive. And here are other examples. It's important to make sure that the slot of the core of the needle goes right in the lymph node, especially in small lymph nodes that we don't take. We have to make sure that the core has taken part of the lymph node, not just muscle and fat in the surrounding tissue. Okay, so marking of the lymph nodes, and this was a big discussion earlier on today in several sessions. Now let's continue that. How does a marker look on mammography? Okay, this is how a marker would look on mammography. Any marker would look just like a metallic density within the lymph node. Okay, this is how any marker would look. The shape might be a bit different, but most of them have just almost the same appearance. So some of the markings we use: clip marker, which is available in Egypt; scout reflector, which is available in Egypt; gamma probe as well is available in some hospitals; and the mag seed. Okay, mag seed is not available in Egypt, unfortunately, but it's also it's popular abroad. And there's also carbon injections, which I haven't personally used, but I have used the clip marker and the Scout reflector. This is how the reflector or the clip would look on ultrasound. Also, again, a hyperechoic density within the lymph node. So in our experience, we've used the clip marker, and as one of our colleagues was saying that the reflector left the lymph node, the clip marker also leaves the lymph node, so I think it's variable. With the Scout, we have not had any problems in our experience. And with the clip marker, unfortunately, we need to do a wire localization for that, and that's very difficult to do in the axilla. However, with the Scout, I think it's easier to use the probe to show us where the magnet, with the radar, to show where the radar reflector is with the special machine that Dr. Sharif Naguib had showed us. Abroad, the mag seed is very popular, yet unfortunately we don't have it in Egypt. Okay, so what's the take-home message? The take-home message for the radiologist report to be proper, we have to comment on the shape of the lymph node, the size of the largest, especially if she's going to take new adjuvant, so we can do her a follow-up report and say what the size is in follow-up. The cortical thickness is important, yet it is not as specific as morphology. And we should comment on if it's symmetrical, focal, or lobulated. The hilar, is it indented? Is it lost? Are there discrete or amalgamated lymph nodes? Is there extracapsular infiltration? The level of affection, level 1, 2, 3. Don't forget the supraclavicular and internal mammary. The number of lymph nodes is important, okay, because that will affect the staging, especially if there are less than 3 lymph nodes or more. And also comment on the vascularity and the presence of calcifications. Okay, so this was my last slide, and I thank you very much for your attention. Thank you.
Thank you, Professor Nouran.
Thank you.
Professor Dr. Ahmed Tariq.
Thank you very much, Dr. Nouran, because you made a statement here very clear that we depend mainly on the axillary assessment on ultrasound. I don't think if we have a suspicious axillary lymph node by ultrasound, we're going to resort to an MRI, as you posed, because many of the cases, the lymph nodes are by ultrasound okay, and when we, for some way or another, when we shift them to do an MRI, the report comes that we have suspicious axillary lymph nodes. And you definitely explained that the normal lymph nodes can even take the dye and there is a washout.
Yes.
So I don't think there is a place for a second look by MRI if the ultrasound is suspicious. As we heard in the panel, I think there is no role for the MRI. What do you think about that?
I think MRI's role is to stage the breast, but because we do the study for the breast and the axilla, so we have to comment on the axilla in the report. But its role is to stage the breast, to look at the extent of disease and if there's any contralateral foci or anything like that. However, in my practice, when I have a patient coming for breast MRI, I would take her to the ultrasound room after the MRI if she doesn't have a recent ultrasound to check the axilla, and I would write that in my report that complementary ultrasound showed no pathological lymph nodes, or there are pathological lymph nodes.
I think there is some technical problem with the MRI to see the axilla because the position of the patient and dropping of the breast. So it's not accurate in MRI. Correct?
Usually in advanced machines we can see them, but we cannot evaluate their morphology properly, which is why, as Professor Rida was saying, the PET MRI may help us by looking at the SUV.
By the PET CT. PET CT. Is there a rule for PET CT to assess the axilla, especially in the current cases after surgery?
Well, the PET CT would be important. Well, usually it's not asked for in stages 1 and 2, so it's after stages 1 and 2 and some of stage 3, correct? And it depends mainly not on the morphology, but of the SUV value. So it can have some value. However, in some literature, in most literature reports, it's not as accurate or specific in masses or lymph nodes less than 7 millimeters.
But in many clinical situations that we, in PET-CT, we have SUV max more than 3 or 4, and by ultrasound it is free. Do you consider it as free axilla? Or?
It has happened quite a few times, and sometimes it is free. It is, we take a biopsy then because it's, they're not concordant together. So we've been asked to do a biopsy, and sometimes it is negative, and sometimes it is positive. So there's no definite answer for that.
Dr. Yasser?
For biopsy on axillary lymph node, okay. In panels, we say, okay, we can do true cut, safe, and there is no problem. But if you have infraclavicular or supraclavicular lymph node, for the true cut, which you will prefer? You will do true cut safe, or you will proceed to fine needle?
I have done actually core biopsy for several infraclavicular lymph nodes without a problem, and we put wire in them actually for Dr. Sharif Naguib before.
But what will get benefit from this? Okay, if I do fine needle, the benefit, I want to know positive or negative. I will not check the biological behavior or something like that. It will not be hazardous to do something like core biopsy in the infraclavicular or supraclavicular lymph node?
Well, it all depends on the vascularity around the lymph node. So if it's accessible, we do it. And fortunately, in the cases that we went through, it was accessible. There was no
risk.
We didn't need to be afraid from the vascularity. Yet, why we don't do fine needle in our practice? Because we find a lot of false negative results. And in the cases where we did biopsy from level 2 lymph nodes or infraclavicular, there were special situations. There were cases that have taken treatment, e.g. post-mastectomy, e.g. post-conservative, and the recurrence came only in this area. So this is the only area that can be biopsied.
May I add something, please, here? I just have a comment to your question, sir, and like Dr. Nouran just mentioned, I'll state it clearly. No problem of doing true cut biopsy by ultrasound guidance for level 3 or supraclavicular lymph nodes. No problem at all, provided a good radiologist capable of doing that and using the color Doppler for the supraclavicular in particular to avoid puncturing a vessel nearby. But we do it very simple, very clear, and no problem at all. And very safe, yes. But provided not just any radiologist, has to be trained radiologist. Thank you.
Yes, please. I have a comment about the extracapsular invasion in case of lymph node. This is an important point. If there is significant extracapsular invasion, this is an exclusion criteria to Z11. You have to do axillary clearance if you have this. So what is significant? If it is more than 2 millimeters. So this is a message to our dear pathologist. When you say extracapsular invasion, you have to measure it. If it is more than 2 millimeters, I have to do axillary clearance. If it is less than 2 millimeters, you can escape the axillary clearance.
Thank you.
Final comment, Bardo, about the same issue. We do comment on the extracapsular invasion as well as the matting of the lymph nodes, the fixation of the lymph nodes, and the adherence to the axillary vessels as well. These are all signs by ultrasound that we can comment or we should comment on. Thank you.
Dr. Nouran, thank you very much. And I want to ask about the perinodal edema sign that you told us that it is 100% sure this is positive lymph nodes.